So this is Andrew. Andrew is 18 years old, and of course he's got 4 third molars that just are not going to be coming in a very good spot, right? He's probably starting to experience a little bit of discomfort with them, looking at where they're sitting, and the time has come to explore getting them out. So I see something immediately in this image, and I'm curious if you do too after listening to the other videos I've done. I think I see it because I'm traumatized by it. But maybe, of course, you've listened and now you're traumatized just from listening to my story. But I see this over here, right? And what I'm noticing is there's an odd shape to that tooth, right? So the tooth here has kind of that, what I call a boot-shaped upper third molar, okay? And when you see those boot-shaped upper third molars, we can actually see it pretty good here. This is the central groove of that tooth that goes all the way through here. And, that's kind of distorted in terms of what it would actually look like, okay? So that tooth is like double wide, basically, which when you look at the pan, you think, oh, it's just a little dinky tooth. There's no problem with that. There is a problem with that, okay? So just know that you're going to need more access up here, and you're probably going to need a little bit more pressure than you might expect to lift that tooth down and out, okay? So make sure that when we approach this, so what we'll do is we'll make our incision with our 12 in behind here. We hit the back of the tooth with it, drag it along the surface, and then we're going to loop it up and around here. We'll undermine the tissue really well here, and again, make sure that once we do that, we have good access to the mesial for our elevator up in here, and also make sure that we have lots of space in behind here that's been opened up as far as the tissue, and then make sure that all our lingual tissue is freed up off of that area as well, so that there's absolutely nothing impeding this tooth, okay? As you start to work at it, again, don't be surprised if you feel some resistance to that tooth wanting to come down. And as you're elevating, you're going to see there's a great big, like super wide tooth that's all oblong shaped that's going to want to come out that way, okay? The approach is the same, so just the elevator goes in, you work it to try to lift it down, occlusal buckle, and yeah, all should be well, okay? But just the big takeaway here is make sure that you have lots of space to work in, and know that these can be a bit of a headache. On the other side, I'm much happier with the appearance of this one. My heart rate is going down. Life is getting good again. The sinus, of course, we see, kind of comes up around there. Not really concerning. The depth of application is a little higher here, right? So we're up near the middle to the apical third of that second molar. Means that, again, that the case is a little more advanced. So if you're early on or new to taking out teeth, I shouldn't say new to taking out teeth. If you're pretty new with third molars and you're looking for a case to maybe try out to kind of push yourself a little bit, this probably isn't the one, right? But if you're fairly comfortable already doing lots of these impactions, this is no big deal, okay? So the 12 needs to come in here. Again, we cut distal. We're going to make our incision along here, loop it around. And this guy here, there's no harm, again, doing that vertical release if you need. We undermine, again, we want to undermine more like this, where we're doing less at the mesial, more at the distal. Once we lift that off, we're going to see what kind of access we have to this area. Again, if there's any bone that needs to be clipped away or removed with that rongeur, we would. I don't see anything along here. Sometimes, again, we'll see that little kind of eggshell radiopacity there that is, kind of showing up there, that little cortication there, which indicates that there's often some bony covering. I don't see it, so my expectation is we're going to have a clean shot at getting the elevator in there. Then we just take that 60B spade elevator, we're going to get up into here and push apically, and this too should displace fairly nicely down and out for us, okay? When they're high up like this, I always prefer, again, to have often more access, right? So that's why I've added that vertical release. And always make sure that your distal tissue is either open enough that the tooth isn't going to get snagged under it and want to go in that direction, or that you have an instrument kind of in behind here, okay, whether that's your Minnesota or your periosteal. I tend to lean more towards the periosteal, just the broad end of it. I get the Molt 9 in there, so that just kind of sits behind and shoehorns it out of there as I elevate from the mesial. With that guy there, again, if you do that vertical release, then you want to put a little suture in here, kind of between the second and first molar. That'll help to hold that steady. The rest of it there doesn't really need to be closed up unless for some reason you had some troubles back here, or a sloppy incision or something. Then you might want to try to close it up a little bit back there too. But yeah, generally if it all goes well with that incision, then it's just one little suture through there and you're good to go. Okay, on the lowers, let's just have a look at those. So let's look at this guy first on this left side. That was a bad circle, wasn't it? So you know the one I'm talking about. So this guy there, we've got a couple roots there, 2, maybe 3 roots, even if we look really closely down in this area. Looks like there's a couple of them. They're still kind of developing, right? So they're not fully formed, which is good news. The nerve, we can see the nerve fairly well, I guess. So right in here, it kind of comes down. That's the inferior border. It's beneath where those root tips are. The superior border is up here. So, I mean, that's going to kind of cross over where we are there. But not much, right? There's minimal contact by the look of it. The roots, are they dark? You could argue that they are, but, I mean, they're still developing. So, again, I'm less concerned with them with this appearance when they're still developing than if they were fully developed and this patient was, 25 years old or something like that, right? But an 18-year-old with, developing roots and a nerve that looks like that, following its course quite naturally, not concerned here too much at all, okay? So what we do with this guy here, we're going to make our incision. So let's say this one, we're going to do an envelope. We're going to come down around here. Start with that, right? And depending on how this tissue undermines and opens up for you, you might want to extend it one more tooth forward. That will give you even more access to be able to lift this flap up and out of the way. Kind of depends on your experience doing these as to what you want to do there, right? It also depends on the depth of the impaction. So again, our elevator needs to get here and we need to expose the CEJ, right? So we have to have the tissue reflected to this level. And so just keep that in mind. I shouldn't say it has to be reflected to that level. The bone has to be removed to that level, essentially. So the tissue has to go beyond that. If you can do that with a smaller flap, that's great, without applying too much tension. If you need it bigger, then of course make it bigger, right? So that's what we're looking at when we're in our minds deciding what kind of flap we're going to use and how we're going to design it, right? Always think about these things ahead of time and why you understand, I guess, why you're doing what you're doing. Okay, that's my hope for your takeaway from these videos, is to get a better rationale for what we do. So once we've reflected the tissue, we're going to see that the tooth is somewhat exposed, right? So often we'll see, some of the tooth, it's kind of gunky on top of it. There'll be some follicle tissue and whatnot hanging out there. Then we're going to just go in here and we're going to cut a little bit distabuccal to there, and we're going to bring this down around the tooth here, okay? And we want to make sure that our trough comes in and opens up all this bone in around the crown, because the idea again is we want to free up the crown so that the tooth has somewhere to move and we have a place to get our elevator into to leverage against the buccal shelf and lift the tooth out. Once we've troughed, are we going to be able to lift this tooth out? Maybe, it kind of depends. If you can get an elevator in here, you might be able to get lucky and kind of lift it up and out. No harm trying it and see what happens. It's going to be tight though, and there's going to be some pressure with that. So again, you could just take another extra minute and just section in through here, right? Once you've sectioned through there, now for sure we're in good shape, right? So you section the way we always talk about, not totally through the tooth. Then you crack that apart with the elevator, engage the distal pulp chamber, and or pulp horn I should say, and lift this guy up and out. Then again, on the mesial, we're just going to get in underneath there and just lift that piece up and back. Okay. You've had a significant bit of bone removal in around here usually. And so with that, there's lots of dust and debris that's going to be in under that flap that you made. You want to open that flap up good, rinse right to the base of it all the way along, and get your suction tip way down in there too, just to clear it out really nicely. The other side is basically the same thing, only the roots are perhaps slightly less developed. Not much difference when I look at the nerve, right? So we're not really seeing much for significant deflection or anything like that. The roots do look, though, like they're maybe starting to turn a little bit, right? So, I mean, that may or may not indicate some proximity to the nerve. Sometimes it does if you get some root deflection, so just keep that in mind. Pretty early on in their development, though, to know, for sure if that's what's going on there. Just to me, it kind of has that appearance. We see we've got some nice little space in around the crown yet for where the follicle is. That's always helpful. What we're going to do with this one is we're going to make an incision, and since we're curious people, we're going to make a triangular flap, and then we're going to call this patient back for a post-op visit about four days later, and we'll assess which one healed better, the right or the left side, right? And we'll do that, just as a tester. I encourage you to do that in your practice when you're starting with these, because it just helps you, I guess, get comfortable with, which type of flap you prefer, and which one works better for you, right? How the patients look after, what was their pain like, that type of thing, and go from there. Get the tissue off of the tooth here, like we always do. We reflect it and get your Minnesota soundly on the bone. So again, early in my career, I would always fight with that tissue, trying to keep it open throughout the procedure. Now my flaps have gotten better to where when I open them, they stay open, right? And I have a spot that's kind of down out of the way, out of the surgical field that my Minnesota can rest on. And it helps to just make things that much cleaner and easier. It's no comparison when you have clean, shiny white bone with very minimal to no bleeding in the operative field versus kind of a chopped up flap that's falling closed and trying to get in your way. And meanwhile, as you're struggling with it, it's swelling up and it's getting harder to keep open because you're handling it inappropriately, right? And it's bleeding all over the operative field, right? So take your time to plan your flaps really, really well. That's half the battle, honestly. Once you can see the tooth and get good access to it, you're good. You're good to go. You can do these cases. It's no different than elsewhere in the mouth, right? I've said that before. It's just your angulations and your approaches and whatnot are just a little different to get used to. So we've got our flap open there. Let's say that's good to go. We've got a tooth here now that is fairly covered up, right? So are we going to see much of this guy? We may or may not. My suspicion is we're not going to see much of that tooth. Maybe a little bit on the occlusal that'll be exposed there. So what we want to do is we want to find it and uncover it. So we're going to just take our burr and we're going to start to paint along the outside of it. So that's the best descriptor I could use. Paint along the bone until you start to find the crown. Once you've identified the crown, now you can kind of lean against the crown with that burr and go in and clean up your trough to make it take the shape of the tooth, right? So go all the way around. And again, we're trying to go sort of distal buccal just a little bit, right? So our trough is going to end up being kind of like this. And then again, we do a little bit kind of down in here just to get somewhere for our elevator. Now you've got two choices. So this guy here, you could use that purchase point that I've talked about before. It likely would work with the Cogswell B just because your roots haven't developed yet, right? So they're open apices. It's a young patient. There's room for the tooth to move. Probably you could punch a purchase point in with the Cogswell B and lift this out in one chunk, okay? If you did that and it was unsuccessful, then you can always go back and you can section the tooth. So same thing, you just start at the pulp chamber, section up this way, take out your distal root by engaging that distal pulp horn, and then come back in here and either use the purchase point that you've already made or get in here with an elevator and lift that piece up and out. Okay, So style points if you use the Cogswell B, and no shame if you have to use your regular elevator either. It's what's best for the patient and what works for you, right? There's no right or wrong instrument. It's just whatever works in your hands, okay? So yeah, great case again, and we'll check out another one in a minute.